Welcome, everyone. Hi, thank you so much for joining us today for our Schwartz Center Compassion in Action webinar, which is titled Fostering Organizational Wellbeing, the Role of the Chief Wellness Officer. I'm Stephanie Adler-Yuan. I'm Director of Programs here at the Schwartz Center. And just a quick introduction to the Schwartz Center, although I know many of you are familiar with our work. We are a Boston-based nonprofit organization. We've been around since 1995, and our goal is to advance compassion in healthcare. Our work has long been focused on improving relationships of care so that we can foster healing healthcare systems. And as many of you know, we focus not just on patients and families' experiences, but those of the healthcare workforce as well. Last month, some of you were here for a webinar. It was really phenomenal. It turned out to be an incredibly robust and pragmatic discussion about actions that healthcare leaders can take now to support the healthcare workforce. We actually can post a recording of that discussion in the chat. You'll find it on our website in the Compassion in Action webinar archive. So if you haven't taken a look, we encourage you to. But if you did participate, you might have noticed that one of the things our panelists named as an action that's important to supporting the healthcare workforce is designating an individual who can lead the important efforts that organizations really need to see put in place. And so that's what we're going to focus on here today. We'll introduce our wonderful guests in just a minute, but before we do, I just want to share a couple notes about logistics for today's session. The program will last for 60 minutes, and most of that will be a panel discussion. So we'll do that for about the first 40 minutes or so, and then we will definitely have some time for questions, as we always do. You can enter those questions in the chat, or you can enter them in the Q&A pane throughout the discussion, and we'll ask you at the end as well to share any thoughts that you're having. Note that we are recording this webinar, and we'll be posting that recording tomorrow in case you'd like to share it with any colleagues who weren't able to join us. Last but not least, I want to acknowledge that this webinar, like all of our Compassion in Action webinars, has been funded in part by a generous donation made in memory of Julian and Eunice Cohen. We are so grateful for that support. And with that, that's it for me. I'd like to ask my dear colleague, Dr. Beth Lown, to introduce today's moderator. Dr. Lown is Associate Professor of Medicine at Harvard Medical School and Chief Medical Officer here at the Schwartz Center. And I know she's excited about the conversation we're hosting here today. So over to you, Beth.
Thank you, Steph, and thank you, everyone, for joining us today. I'm really excited about this conversation we're about to have. And you're about to meet a really important and exciting group of leaders who are contributing to the change in conversation about health and well-being from the boardroom to the workforce, so that we hope we will encourage some additional attention to the importance of workforce well-being among healthcare leaders and those who are caring for patients and families every single day. So I am going to begin by introducing our esteemed moderator, Dr. Jonathan Ripp. And Dr. Ripp is a professor of medicine, medical education, geriatrics, palliative medicine, dean for wellbeing and resilience, and chief wellness officer at the Icahn School of Medicine at Mount Sinai. He's also co-founder and co-director of CHARM, which is a collaborative for healing and renewal in medicine that you're going to hear more about during the course of this conversation. Also joining us is Dr. Hein, joining from Portland, Maine, Chief Wellness Officer there at the Maine Medical Center, Associate Medical Director for the Department of the Emergency Medicine, and also Associate Professor of Emergency Medicine at Tufts University School of Medicine. Dr. Stephen Keithahn, Associate Professor in the Departments of Medicine and Child Health at the University of Missouri School of Medicine, and is MU's Health's first Chief Wellness Officer, and also serves as Medical Director at the Woodreal General Internal Medicine Peds Clinic in Columbia, Missouri. And finally, and not least by any means, is Dr. Mariah Quinn, Chief Wellness Officer at UWHealth and Associate Professor of Medicine at University of Wisconsin School of Medicine and Public Health. We are really excited to get this conversation going, and I am going to turn this over to you, John, to lead us off as moderator.
Thank you so much. Really a pleasure to be with you and all of you joining in today, and just great to have this opportunity to share a bit about what we're doing and engage in a discussion today. Hear a bit about the role of the Chief Wellness Officer and how organizations can commit to the well-being of the workforce, and then hopefully We'd love to have time and hear from those of you who are joining in. So please do feel free to enter those questions, as they come up along the way or at the end, so we can be sure to field and hear from you. What I think we will do to get started is spend just a few minutes sharing a bit about ourselves, to let you know how we got into this role and sort of what it is we do, the scope of our role and our responsibilities, maybe a little bit of what we've done in the early part of our role, maybe some early wins, and perhaps some of our early challenges that we faced. And then I'll in particular share just a tiny bit about CHARM before passing it along to the panelists. So as you heard, I am in New York City at the Mount Sinai Health System, the Icahn School of Medicine, where I've been pretty much since I finished my training in internal medicine. I'm still a practicing general internist and see patients through our house call medicine program here in New York City. I do that 30% of my time now, and that's been the way I'd say since I took my role as Chief Wellness Officer about 4 years ago, just over 4 years ago. I came to Mount Sinai originally as a clinician educator and academic general internist, was spending most of my time in doing clinical work like many clinician educators do, but was in those early years sort of interested in finding what would be my academic focus. And I remember reading some of the very early papers looking at burnout in resident physicians, and found that to be really intriguing, and thought, why not explore this myself and see about whether I could do some survey-based research, and really, so my story is one of kind of slowly expanding scope and interest. So back in those days, this is almost 2 decades ago now, there certainly was not a lot of, or certainly not anywhere near the kind of discussion or focus around the well-being of the healthcare professional workforce or learners. That was in many ways, I think it was a curiosity more than anything else to those that I explained what it was I was interested in studying and focusing on. And so, I often think that I kind of picked a winner in a way of choosing an area that was soon to rise rather dramatically in terms of recognition and the momentum. So I become more involved not only in research, but in a role overseeing well-being for residents, and again, kind of being in the right place at the right time, having an early associate dean role for GME level well-being. I was already positioned such that when our institution felt that it was time to make more of a full thickness commitment, I was already kind of in the room as someone who had established a level of expertise. So like many of us, our path is circuitous, and certainly I had a lot of folks who mentored and sponsored me along the way, and I couldn't have gotten here without them. In broad strokes, my role is large. A lot of what I do is measurement. So I represent the person who kind of understands how to oversee a team that can measure, kind of take the pulse of where various folks within a healthcare system are doing as it relates to their well-being. I then disseminate that information to a variety of stakeholders and leaders in the hopes that will spark sort of areas that they can prioritize. I do help provide consultation to them in terms of what to do with that information, and also a smattering of some running some well-being related programming, doing some advocacy around that, and we do while it's certainly not the case for every institution, we do a fair bit of well-being research. Early on, I'd say things that I'm proud that we've been able to do is create an infrastructure around well-being, and we're happy to talk about that more. But we have Wellbeing Champions positioned in various departments and training programs, and that enables us to really localize the issues for the groups. And we've created a nice cohort, over 100 folks at this point for our healthcare system, which is about 40,000 plus individuals, 8 hospitals, urban focus, of course. I'd say ongoing challenges, just remain the significant burden that we know our workforce experiences, and sort of how we continue to face the psychological toll of the pandemic, and what we know to be the burnout that we see commonly in our workforce, and how do we continue to drive forward change that begins to bend the needle on the numbers that we're seeing. And so that continues to be an area that we really are concerned about and are challenged with. Lastly, I'll just share a bit about CHARM. CHARM is the Collaborative for Healing and Renewal in Medicine. It's what began as a grassroots group and now really more of a formal organization that serves to be the professional home for well-being leaders. And we do basically, we got started because a number of us got together and said, we don't want to just measure this problem. We want to identify ways of making an impact. And so we do that through a series of networks and learning communities, working on publications and research and so forth together. And it's a great way that those of us in this space can connect. So enough about me. I want to make sure we have time to give equal footing for our panelists, who you're no doubt interested in hearing from. So I think first I'll ask Dr. Quinn, Mariah, if you could also share a bit about yourself and what you do. And we're delighted to hear from you. So thanks for coming.
Sure. Thanks, John. Really excited to be here today with wonderful colleagues. In terms of my background, a lot's going to sound actually fairly familiar from what John just said. I'm also an academic general internist and really sort of came up as a clinician educator with a focus on residency education. I'll say that I became interested in well-being work really due to actually personal experiences. I found myself very surprised as a medical student as the first physician in my family, not only many of the things that I saw in terms of kind of suffering I hadn't quite imagined before, but also how that impacted myself and my colleagues. And that interest really grew over residency and turned into, as it does for many analytical people, research questions and questions about why it had to be that way and questions about how we might make it better. So when I completed residency, I did a general medicine fellowship, really focused on the question of how much research I wanted to do. So I had to figure that part of my professional life out, and also gave me the opportunity to really cut my teeth a little bit more as a medical educator, taking on some curriculum development role, really focused on humanities and sort of the crossover into well-being and relationship-centered care skills. After fellowship, I spent a few years kind of working as a general internist and in a few education roles, and then moved to Wisconsin, which is where I'm from originally, to be closer to family, and became an associate program director for the internal medicine residency here. And during that time, I was in that role for about 10 years. I was really able to engage in, of course, mentoring and really looking at how we could shift kind of the culture and the system within the residency to improve well-being, curriculum development, really focusing on those core dual skills of relationship-centered care and personal well-being. And over that time, kind of in the way John talked about, things just sort of grew. I got myself into places where it became clear that I could sort of help meet some of the needs of faculty and others. And in 2019, I became the representative from my very large department of almost 500 faculty to sit on our newly formed provider well-being committee at our organization. That was part of, I would say, our organizational well-being journey was starting that committee. And around that time, I was able to work with my chair to carve out a very small amount of FTE to really focus as the inaugural well-being director for my department. And as in John's story, that kind of situated me such that when the chief wellness officer role was created at my organization, I was situated to know about it and to apply for it and already to be sort of doing some of the work. So some of the work that I'm very proud of that we've managed to accomplish include starting our system-wide peer support program, which we were able to start in very rapid fire at the beginning of COVID, in part due to a really successful local pilot in our Department of Emergency Medicine. I'd also been trained as a peer supporter in my time in Boston before I returned to Wisconsin, and we were able to train almost 100 peer supporters within a period of 3 weeks. And really seeing that program grow and blossom has been exciting. In terms of how I think about that program as Chief Wellness Officer. I act as a peer supporter in the program. I do trainings, but I also started something called Executive Wellbeing Rounds, where I invite other executive leaders at my organization to round with me on units. And we've mostly focused on COVID affected units to really help them sort of think about when they're doing a lot of what they do routinely, which is rounding and doing go and sees and things like that, how they keep well-being as a question at the forefront of their minds. We've also really been thinking about our well-being infrastructure. And I'd say ours is not as well fleshed out as yours is yet, John, with Wellness Champions, but really working on helping our departmental representatives on our well-being committee be really active in local level action planning and really empowered by their chairs to engage in local level work, which is so important. And there are all kinds of other projects going on that are just really important in terms of supporting well-being resources like a critical incident response protocol that we're creating, and lots of exciting work to do, still kind of in early phases of that. Why don't I stop talking now and pass the mic along to Steve.
Okay, thanks, Maria. Good afternoon. I'm also honored to be here today, and I certainly appreciate the work of the Schwartz Center. I'm an internist and pediatrician at the University of Missouri, primarily an ambulatory specialist, and I lead our MedPed teaching clinic, and I've been here for over 11 years. Prior to that, I worked over 15 years in private practice settings in the clinic and in the hospital and the emergency room. And like Maria, I've been interested in physician well-being almost since the onset of my career. Early on in medical school, I realized that being a physician not only required physical and mental toughness, but also emotional grit as well. And that, a physician or medical student could go to a disturbing, emotionally traumatic patient encounter and then be expected to just go on to the next encounter without having time to process those emotions. And I recall in my first job out of residency in the 90s, I attended a lecture on physician well-being given by two Duke PhD researchers. So as John alluded to, physician burnout is not a new concept or problem, but it's probably as bad as it's ever been, at least in my career. And until I started this work, I really thought of physician well-being as being mostly a personal resilience issue. And actually, shortly after I came to MU 11 years ago, I gave a grand rounds on well-being that was focused primarily on that. More recently, I was serving on a physician professionalism committee for our faculty practice group, and the issue of burnout came up as a cause of professional lapses. So I was sent by this committee to the 2017 inaugural American Conference on Physician Health that was put on by the AMA and Stanford and Mayo. And I think the epiphany or aha moment for several of us who attended that meeting was that burnout was much more likely to be related to the work environment, and they estimated about 80% of the time, rather than a lack of resilience. So there's no way to yoga or meditate your way out of a toxic work environment. And so if you attribute burnout to primarily to lack of resilience, in many ways, you're blaming the victim. So I was sitting in the San Francisco airport on the way home, and I realized that MU could benefit from a well-being program, and I thought that I should lead it. So I got home, I pitched the idea to a committee member who happened to be head of finance for both the School of Medicine and the hospital. And he became one of my first of many allies in leadership. I then began a tour with senior leadership of both institutions, preaching the patient care and the financial benefits and the moral obligation of addressing physician well-being. So in September 2018, almost a year after the conference, I was appointed MU's first chief wellness officer. But in typical Missouri show me state mentality, I was given just a half day a week and no budget. So I spent the next several months developing a concrete business plan. And then finally in 2019, I was given a budget to hire a full-time director who also serves as our psychologist for our safety net program and a 0.5 administrative support person. And both of them started in the summer of 2019. So by the end of 2019, we had our EAP-like safety net program up and running. We had completed our first burnout survey, and we had an agenda for 2020. Then the pandemic hit. So like most well-being programs, the next 2 years focused on safety net, personal resilience, promoting a healthy culture, and it was much less about how to improve the work environment. But in 2021, we were able to administer a more detailed burnout survey. And this year has allowed us to reset the agenda and start working on proactive initiatives to improve burnout and enhance well-being, which we are quite involved in. Our four main initiatives this year include taming the patient portal, which we found is much more harmful to physician well-being than our EMR, optimizing healthcare worker safety and reducing violence from patients, which seems to be a national problem, addressing physician depression, and then reducing the gender gap in burnout, because as in most institutions, our female physicians have higher burnout scores than our male physicians. So that's enough about me. I think I will turn it over to Christine.
Thank you. I'm really appreciative of being here today. And my name is Keithahn. I'm the Chief Wellness Officer at Maine Medical Center. And my path has some similarities to the others and then a few differences as well. I think I really sort of stumbled into this work by saying yes to a subgroup of our medical staff committee, and it was looking at forming a peer support program. We had a provider health and resiliency committee that was non-functional at the time, and it became obvious that our staff needed support, not just our provider staff, but also our nursing staff and other clinical and administrative team members. So we worked over the course of a year from 2013 to 2014 to develop a comprehensive peer support program, do training around our organization and roll it out in the middle of 2014. And, that complemented some of the work that I was doing within our emergency medicine group at the time when I had been appointed as an associate director of emergency medicine and really saw my role more as a people person in that position. And then I was able to expand that over the course of multiple years to our entire organization. So we started doing annual assessments in 2017 to gather data. And then I've been able to use that data to meet with leadership, executive leadership, department chairs, and medical directors and share data on their individual teams that they can use to help improve the well-being of their entire teams. Since that time, I think it was 2019 that I was officially appointed the Chief Wellness Officer. So there was a lot of work that sort of went into this process before we ever really had a program or any sort of infrastructure. I'd say at least 5 or 6 years of work. Then very shortly after our program was named and we developed a strategic approach and plan and some comprehensive initiatives, COVID hit. And so we, at that point, had a peer support program that was actually fairly well trusted amongst our team members and our workforce. And so that it proved to be extraordinarily important during the early phases of COVID. We developed group mental health check-ins for different members of the clinical care team that we held on a monthly basis and did that in collaboration with our psychiatry and social work departments, as well as spiritual care. And I think that's been a big piece of the work for us is collaborating with others who are doing similar work and really using each other's resources and ideas to help pull the entire organization along, if you will. We have also developed a provider support program that actually fills kind of a unique need in between mental health resources and peer support, and that's for looking specifically at work-life imbalance, burnout, and professional challenges that providers face. And then just most recently, we've offered a virtual mental health platform to our entire organization across our health system. So that's over 20,000 individuals. And that makes counseling resources immediately available in a virtual platform. And that's also for people's partners as well as their dependents. So that's been something that we just rolled out actually in the last month, and we're spreading across the system. We've developed a council of well-being directors so that we're trying to connect people in the front lines with leadership. So when we meet and present our annual data, We're meeting with leadership as well as their representatives to our council to try and kind of tie those relationships together and advocate for the work that needs to be done to improve clinical efficiencies and decrease, daily frustrations that people are experiencing. So those are some of the things that we've done at Maine Medical Center. And of course, there's always more work to be done. That's probably one of the most rewarding things about this work, is that you can take it in many different directions. So that's enough about me.
Wonderful. Thank you so much to all of our panelists. Hopefully the audience can get a sense that there's no real one path to being a chief wellness officer, although hopefully we are helping to set a standard so that this becomes a much more common position given all the needs that are out there. We have a number of questions for our panelists that I'm going to dive into and then save some time at the end. I do see that there's a bit of a robust discussion already in the chat, which is great. That's what we want. It's a little hard for me personally to toggle back and forth. Although let me just start by addressing at least one or two comments about who chief wellness officers oversee, which constituents and health professions within a workforce that our efforts are directed at. And I'll just very quickly say before asking some questions of our panelists that, historically, I think just by virtue of how this issue has been studied, admittedly, the literature tended to focus on physicians. That's where this was kind of first highlighted. Very clearly to all of us who are in this space is a recognition that the work that we do cannot focus on a single segment within the healthcare workforce. And I agree. I think some of the comments about what we're seeing with nursing right now is a huge challenge with not only those who are leaving the workforce, but the challenges that our nurses are facing. So none of us in our positions feel that the work can focus on any one segment. Each chief wellness officer you've already seen are sort of focus. Our job description and roles and responsibilities vary a little bit, and that sort of depends a bit on how each institution makes its commitment. And we can certainly speak to that a little more so. To date, there are very few nurses that sit in that chief wellness officer role, and I'd love to see more in that position. Certainly, there are more and more emerging nursing leaders that have a well-being leadership role, and we very much want to engage with those folks because we know that we have to. We know that we have to pay attention. And I did see in the chat, it's not about just doctors and nurses. Also, it's about all health professions and all stages of learning, whether you're a student or a resident or beyond. So I just want to make sure that that's clear and that that's where our commitment lies. With that, let me ask some questions of our panelists, and then we will certainly aim to engage further with those of you who are joining today. So Mariah, a question for you to get things started. Prior to the development of the chief wellness officer role, probably before 5 or 6 years ago, there weren't really too many of us at all. There were leaders within healthcare systems who kind of had a wellness or a well-being role. And can you speak perhaps a little bit to how the role of the chief wellness officer might differ from some of those previous roles or even roles that are currently in the system that might overlap a little bit with focus on well-being or wellness?
Yeah, absolutely, John. In fact, I would say in some senses, I think I used to occupy one of those roles. And I think there really is an incredible need for well-being leadership that is really broad and strategic, as well as serving as sort of a coordinating and catalyzing role. And I think chief wellness officers really exist in this specific niche. So, for instance, within a lot of our organizations, there may be leadership centered on, say, emotional well-being, say someone who leads a peer support program or a behavioral health clinician, or it really could be anyone who has done a lot of work that is high value within their organization that improves well-being. And this leadership is really critical. It also potentially has some limits on ability to have really broad impact if that's the primary focus. So, I saw one of the questions in the, I think it was in the Q&A that I was just peeking ahead at, was really about, are we looking at the work environment? And that is one place where Chief wellness officers are really situated to sort of help support and amplify and coordinate the emotional well-being or resilience focused work, but also to help with efficiencies and daily hassles and daily frustrations, like the patient portal taming project that Steve mentioned. So, I think in my role, I see a lot of what I do as helping connect operational leaders, which could be clinical managers, patient safety, informatics, as well as other leaders who really focus on well-being and resilience. And then creating an optimal culture also requires really broad engagement and training of leaders, and as well as operational structures, and really having commitment to do all of that, aligned with the issue of scope. So my scope in my job description really is focused on physicians, GME trainees, and advanced practice providers, but I work very collaboratively with our chief nursing officers at our sites, with the Nursing Wellness Council, knowing that I can help support and amplify their work, even though they're not directly in my scope. So one of the things I really love about my role is that I get to sort of be a glue with a lot of situational awareness to connect people who are already doing the good work that we just really need to spread.
Thanks so much. Yeah, I really appreciate your perspective on highlighting the system and the role that the chief wellness officer can fill in dealing with those big issues. And certainly, I can comment on it from the perspective of time, having been in this space for a while. I think a decade ago there were no well-being leaders. So I think it's great that every institution is kind of on its journey and are at a different sort of stage, and we're all pushing for this to be totally mainstream and integrated across disciplines, across the health systems and the health professions. So with that, Steve, let me ask a question of you at this point. We are hopefully emerging from COVID, or at least, dealing with it in a different way than we were in these last 2 years, hopefully. Can you speak for a little bit about how your role might have changed as a result of the pandemic, how you might have pivoted and are perhaps pivoting back or not pivoting back? What can you say about that?
Yeah, thanks. I just wanted to comment. I love Maria's metaphor of being glue to connect all these different initiatives that are going on with an institution and bring people together for all the same goals. Right. So when the pandemic hit, like most everyone, all aspects of my life became more challenging. So I had to decide how best to take care of myself, my patients, the staff for the clinic I lead, and the clinicians at our institution who I was responsible for. And as I mentioned, the emphasis of our work became much more reactive, primarily as a safety net and resilience program. I will say that one of the benefits of the pandemic, however, was that we were asked to join forces with institutional well-being champions on the hospital side to address workplace well-being for all of our healthcare workers. And I think that really moved us along faster than we would have done so on our own. And we built relationships that we've really benefited from to this day. We also learned that even in the bureaucracy of an academic medical center, when you have the right people, the motivation and proper resources, things can happen very fast. For example, we helped we repurposed a campus dorm to serve as an infirmary for healthcare workers sick with COVID, and isolation housing for COVID-exposed healthcare workers who didn't want to bring COVID home to their families. And we also set up an emergency daycare for our healthcare workers. And all of these programs were up and running literally in days, not months or years. And so I remind our leaders about this not infrequently as we're trying to move things through. I will say my main regret that as a new program, we did not have a presence in our incident command structure. And I think that had we been at the table in ICS, we would have been able to help keep our people healthier and functioning better during the pandemic. I'm kind of curious if other panelists were there.
Yeah, thanks, Steve. I really appreciate your perspective there. Well, I can answer that actually in our incident command. So I was not initially, and like a lot of the work that we do, I'm sure this will resonate with panelists. we have to really advocate, and a lot of what we do is lead by influence, because when it comes to trying to change the system in a way in which you can steer the healthcare system ship in a direction that promotes and enhances well-being, you really need the help of those large operational groups that manage the system, right? So we have to we're constantly advocating and trying to influence. And it was really at the end of our first wave in New York City, which was very dramatic, that they then recognized the need to include a well-being representative in the incident command structure. And so after the wave was finished, they then integrated us. So moving forward, we are now part of it, which is better than not being there at all. But it took a pandemic to recognize that maybe this is should be one of the incident command critical components. So with that, Chris, question for you. So now maybe we're pivoting back after the wake of COVID. Have your priorities changed, remained the same, or did some of them change and pivot back? What are the major challenges you see now at this phase as it relates to well-being in the near term?
Yeah, it's a great question, and one that we've spent a lot of time thinking about as we wonder, are we nearing the end of this pandemic or just approaching the way we're going to be living with it for some time? And I think our priorities really haven't changed, but they become more acute than ever. I feel that the biggest challenges that we're facing are our lack of resources in terms of workforce shortages, and then also the impact of the pandemic on our workforce's mental health and emotional well-being. And so our program was actually fairly well established because those were the things that we found in our peer support program that actually drove the development of our well-being program overall. But it's become very obvious that we need more resources, and we need them in a very rapid period of time. We know that our local rates of burnout have substantially increased. We've been measuring it for 5 years. We're in the middle of our 6th assessment now. And we saw the biggest jump that we had seen during that 5-year period between 2020 and 2021. And that mirrors what's going on nationally as well. And that's been very helpful data to present to leadership and decision makers and say, these are the kind of compelling arguments that we have to make to support our staff. We've also had to work in environments where we're short-staffed, whether it's in the inpatient setting, the outpatient setting, administrative support. It's impacted our entire organizational system. And I think we understand what a detriment that is to our patients and to ourselves. So nobody wants to exacerbate that with preventable workforce shortages due to burnout, lack of engagement, and knowing that burnout is a risk factor for development of mood disorders and anxiety. We certainly want to be proactive and prevent that if possible. So that's led to some of the successes that I was talking about and initiatives that I was talking about during our introductory period in terms of establishing more robust mental health services, expanding our provider support program, opportunities for group debriefs for the entire team, expanding our nursing peer support program and our patient care services program. And then I think probably the last challenge is how, with these significant challenges facing us, do we make time for the things that bring joy in medicine still? The things that all of us love, whether it's teaching at the bedside, research, teaching medical students, whatever those things are that kind of shore up our resiliency and our ability to withstand some of the challenges in our workdays. And so that's another opportunity that we have to continue to make time and space for. And I feel that that's a responsibility of our program to advocate for that with leadership, because it would be a natural reaction to try and look for ways to improve clinical efficiencies at the expense of other things that are just as equally important to the mission and the success of the organization. So.
Great, thanks so much. That's a really helpful perspective. And sort of both validating the initial approach that you had prior to COVID and highlighting how the issues that we're seeing right now, they're so acute and kind of informing the path forward. So really great. I do see there's a real vigorous chat going on. That is what we want. Just a couple of quick, maybe one or two more questions for our panelists, and then I think we should dive into what the audience has. So Mariah, maybe just real quick, any thoughts? Not every institution has the resources or perhaps the will to name a chief wellness officer. How might this impact the ability or approach to make change and promote system or institutional level well-being?
Yeah, I love this question in part because I would say at our organization, we're relatively new in the journey of having a chief wellness officer. And so I think having a chief wellness officer is absolutely helpful, but I do want to just speak to some of the strategies that one might use sort of the interim stages to potentially having one, to kind of think through how to overcome some of those challenges. I do think it's really helpful ultimately to have a clinician leader, whether they're a physician or a nurse or a member of another health profession, who really speaks the language of and is of the medical culture. Just really helps in terms of developing vision and articulating it both for organizational leaders as well as for physicians and other staff. But I can certainly touch a little bit on some effective steps that we took that didn't require a chief wellness officer. So I think the first is really formally acknowledging that well-being is, we call it a foundational competency. That just means something that we actually have to be able to do better than we were doing before, or well enough, or as well as we can, in order to actually meet all of the challenges of our mission. Without that, we're just not going to be able to retain people, where people are going to be burned out. They're not going to be engaged in their work. Having that orientation of setting that sort of understanding that well-being is absolutely critical as an underpinning element to being successful in our work is important, but really isn't sufficient if there aren't resources or leadership aligned with it. Many of us know that we exert influence simply by keeping the question of well-being at the table. We kind of become the well-being nudges in a sense, but without having some resources and some organization, it becomes really hard to be effective. One challenge, of course, is that well-being can be lost among a lot of other competing demands, like financial demands, for example. And a lot of organizations try to rely upon other operational leaders like chief medical officers, chief nursing officers, chief HR officers, and others to kind of carry that well-being mission forward. And I think they can be effective to some degree too, but they have much more internal conflict around those competing demands. And so having a leader who's really accountable to well-being as their primary directive is very helpful. As an aside, really partnering with those other operational leaders is really critically important for chief wellness officers to be effective. So we really need our other operational colleagues. Without having a sort of clinician leader doing that work, you can get a lot of traction out of having a high-level skilled, committed administrative leader with some resources. That person can really help maintain that focus and help anchor other operational leaders. Especially if an organization is taking that route, I think developing a mechanism for input and partnership with clinicians and other staff is really important. So this can look like wellness councils, well-being committees, well-being advisory groups, champion groups that report up into a structure. It can be very helpful in terms of making sure that the initiatives that person is thinking about really align with the needs of their workforce. And then just again, as an aside, I would say that having those structures in place actually is helpful, even if you do have a chief wellness officer, because in a large organization, none of us can really be present in every place at every time. And so really having a sense of what different pockets of people need and different professions and different disciplines is very, very important.
Wonderful, Mariah. I thank you so much for that really well-informed answer. And I think I would go so far as to say that if a lot of those pieces are in place and you don't have a chief wellness officer, that's far more important. And you could argue that naming a chief wellness officer without empowering them to do the kind of work and be positioned the way you described is almost like window dressing or checking a box and claiming you're attending to well-being without actually doing it. So, I think we are running up on time here. I had one question that was gonna address kind of different health professions, and we sort of talked about that already in terms of the need to address all. So I might skip over that one and just ask last one maybe of Chris, if I may. And this has to do with sort of how does the CWO navigate all these competing demands that are placed on healthcare leaders that you report to, in order to make sure that well-being continues to rise and stand a chance to emerge as a priority on equal footing with others, say, maximizing revenue and quality and so forth. Any thoughts on that one?
Yeah, lots of thoughts on that one. I'll try to keep it brief in the interest of time. But I think it's a really important question because it's kind of the crux of how to make the case for this. And it's really hard when values and strategy and resources are kind of conflicting, as Mariah mentioned. So I've been fortunate to work for a team that really believes in this, but I've still had to work really hard to advocate for the resources that we need. And of course, we know they're not endless, and they've just recently been even more constrained during the pandemic. So I think the way you frame this discussion is critically important. And I would recommend really a very intentional approach. There's definitely a case to be made for citing numbers around workforce turnover and the financial impact of that. And I think that's a piece of a broader and more deliberate discussion as well. COVID has really shined a light on how important and how essential our workforce is in order to take care of patients. And so now we have the opportunity to kind of grasp the moment, if you will, and use what we've learned during the pandemic to advocate for continued support and funding of initiatives that are going to improve workforce retention, engagement, and reduce burnout. And I say that deliberately. We want to improve the environment and the culture of well-being, as well as reduce burnout. If we focus just too much on reducing burnout, then we're missing a huge opportunity upstream before our workforce is completely distressed. So I think you can frame this with a couple components. It's a very common problem, and there's tons of data and literature to support that statement. You will not have any problem citing evidence to support that. And the second piece is the substantial impact that it has on our organizations, on our patients, and quality of care, medical errors, decreased adherence to recommendations from the healthcare team, on us as individuals within the workforce, on our mental and physical health, and the rate of development of mental illness and burnout obviously is very significantly impacted. And then also on our organizations. And it's not just the financial cost of turnover. There's multiple domains that you can look at when you're trying to make a persuasive argument for return on investment. And that includes patients and turnover. Professionalism is another huge piece of this, promoting professional behaviors. I saw in the chat that somebody was asking about our relationship with kind of professionalism committees, if you will, at our organizations. And you're right, vast majority of unprofessional behavior probably is rooted in some element of burnout or distress. And so we can have a huge impact on that by avoiding it in the first place. And then in terms of recruitment and retention for talent to our workforce, and finally, just on reputation for our healthcare systems. So there's a lot of direct and indirect costs associated with this. And I think that we can make a pretty persuasive argument for why we should continue to promote well-being interventions and why the moment is now, particularly in light of the last 2 years.
Well, you're very convincing. I'm not surprised you're in the role that you're in, the way you answered that. And I think we do want to make sure that we get to the audience. And just before doing so, I just want to make sure to give Steve one last chance. Any other comments you want to make, Steve, before we move on?
Right. I just want to add to Christine, if you're a new program, don't be surprised if you need to re-message frequently. An example of this, we were included, our physician wellbeing program was included on our strategic plan for our institution in our first year, and we thought it was a big win. And then the next year it was left off, and we were like, and so we had to go back and make the same case again. So that's, I think, pretty common at other institutions. So you have to ongoing message because it's just not ingrained in their culture or their thinking yet. Thanks.
Such a great point. Quality never falls off the priority list, so we got to keep charging forward. Beth, why don't we pass it back to you now? I know you've been taking a look at that chat and the Q&A, and I think it's been moving. So happy now to hear from the folks that are joining in.
Yeah, it's really incredible. Thank you all for putting in your questions and your comments and sending each other resources. I would say that the comments and questions we're coming across refer to the business case. You know, is there some place where we can access something like this? Job descriptions give us the formula and the percent FTEs. So I'm just going to list through, and then we could pick what measures are you using, and what's publicly available versus proprietary. How have you created infrastructure, and how does that differ from institution to institution? How do you figure that all out? Some of you have champions, other have peer support committees and so forth. So I guess that's that probably is the bulk of the comments. Christine, you did a great job addressing the business case, and there are other resources. There is an online calculator that's available. I think that's on the AMA Education Hub website to estimate the cost of burnout and turnover and so forth. So there's a lot of materials on the AMA Education Hub. And I know it's directed primarily at physicians, but there's lots of material too for nursing in the AMA Steps Forward. And there's, I'm sure, much more material and resources to be had on some of the other large organizational nursing websites. So let's put the business case aside for a second, but are there any places where we can really find these tools, find what measures there are, find job descriptions? I don't know if that's going to get us into a charm discussion, John, or what.
I could take a crack at trying to answer some of, a fair bit of that pretty quickly. And also, I see there's a lot of expertise amongst members in the chat already, directing many of you to those resources, including that burnout calculator that you spoke of. And Stephanie, on behalf of our group, dropped in a bunch of resources, including one that speaks to metrics. I would say metrics always can really consume the oxygen of the room, and you can really get caught up in terms of what's the right one and how often do I do it and so forth. And there's a good reference that we gave for you to think about how to compare and contrast. My sense, I'd love to hear what the panelists think. My sense is, pick one that's been well validated and studied and just go with it and get repeated measurements. There's lots of ways to do it. You can outsource it to other groups. And the key thing is we need to be measuring. FTE and job description, a couple other resources that we dropped, that Stephanie dropped in the chat on our behalf, capture that to some extent. That question about FTE always comes up. It is variable in terms of within our group. We did publish a piece, which I'll try to drop in the chat before we end, that captures the variability in the role across multiple chief wellness officers, which we published a year and change ago. What I'll say about FTE is I don't think there's a magic number. I will say that it probably should be at least half of your time. It can be hard to get that in some places. Steve gave the example of how he was first supported in the case he had to make. But if for a couple of reasons. First of all, there's plenty of work to do. Second of all, it demonstrates the level of commitment to the organization. If you're saying at least half of a person is doing this, that it's pretty important to do that. I would say so. Hopefully that captures it. I'll go ahead and find that other resource. I don't know if any of the other panelists, Steve, maybe you could speak to that one since you started around the issue of FTE and your thoughts about the optimal amount, what's needed.
Well, I think most senior leaders spend a lot of times doing work on evenings and weekends. And so I think if you're an advocate for this and you're doing clinical work, that's going to be part of your life. But I think you have to be really careful not to get burned out on doing burnout work. And so to that end, I really think, and again, we published that piece, or you published that piece, that with the 0.5 is sort of the threshold. I'm going to be at Point 4 in July and have had to drop other activities and teaching and so forth to really be able to focus on the well-being thing. So I think those of us in academic centers, if we are not properly resourced with time, we have to cut back on some of the other teaching and leadership work that we do to really be able to hone in on well-being.
Great. Beth, do you have other questions for us?
I think people would like to know how to get into the game. Where do you start? Who do you reach out to? How do you build the infrastructure? What are some practical steps to just begin?
Mariah, do you want to take that one?
I don't know that there's a 100% right answer to that, but I think that the story that John and I both shared, and actually, Chris, your story had elements to this too, as did Steve's, were when you become interested in it, to start focusing on it to the degree that you can, and to take every opportunity to become involved and say yes to the things that align with it. It's like Steve just said, you have to be careful not to be burned out, not to get burned out on doing burnout work. So you have to be thoughtful about how to do that. But I think if this is something that interests you and ignites you to take the opportunities to do the work and become connected with the other people in your environment who are doing it, such that as there become more available leadership opportunities in this domain, you're kind of situated to do them. I will just say that doing this work over the pandemic has been both exhausting, but also incredibly exhilarating. Having connections across your institution and seeing what other people are going through and being able to help, improve the environment going forward is something that is just a huge source of joy, even though it's really heavy work a lot of the time. And I'll have others add.
I think in the interest of time, Beth, anything else you'd like to pull from the group?
There's such great questions. This has really generated probably more discussion than we've had in a webinar, in a really long time.
Yeah.
I'm just trying to figure out what would be.
Well, I saw one about the Wellbeing Champion role, and I think there was a fair bit of interest in that, and that's really just reflects the need to, and recognition that whether it's a different, across professions and even within professions, right? So if you're talking about physicians, surgeons versus ambulatory physicians, you're talking about nurses, inpatient versus outpatient, that the drivers and stressors are really going to vary. So having some individual who's kind of dedicated to a given cohort to kind of understand what the issues are and be the person that literally champions those, so that you can then enable that person to bring those issues to in a structure that promotes change. And a lot of that role actually is managing expectations. So if you ask, and there typically is a little bit of hesitation amongst leadership to ask people, tell us what can make your work life better, out of fear that they're going to say double my salary and give me this and that. But there's a way to ask people what their needs are and, manage that discussion and say, we're not going to be able to do A, B, and C, but your ideas around X, Y, and Z are great. And let's talk about that. Let's do something. And that's where a Wellbeing Champion can work. Ideally, someone who's kind of nurtured and followed by a well-being leader. I see Stephanie has come back on. I think we probably could keep this going and going. And you probably want to hear more from folks. But I do see that we are running short on time. So I want to make sure that we pass the torch back to you, and thank everyone for joining and being so engaged and sharing so much expertise. There's a lot of amazing resources that you've all shared. So thanks for being such an engaged audience.
Man, I hate being this guy. It's the worst. No, this has been great. Thank you to Beth and to John and to our wonderful panelists today. And we know this is the tip of the iceberg. I think even just the chat has really inspired us so much. Thomas's comment about the Massachusetts Health and Hospital Association reminded me that here in New York, the Greater New York Hospital Association has also done a phenomenal job just coalescing expertise, because so many of you are doing this work just like the people who lead our Schwartz Center programs are doing this work alone and can't see into other institutions. And so building that community so we can learn from each other, there are a lot of great opportunities to do that. And this was just one of them. So thank you all so much for joining us here today. We hope you enjoyed this. We hope those of you who are Schwartz Center members, I just want to get a little plug, and we have another exciting event this week on Thursday. We're holding our first ever member community Schwartz rounds. It's going to be huge. We don't know exactly what to expect, but we have some phenomenal panelists. It's the first time that the Schwartz Center is bringing our signature program of Schwartz rounds as a forum where we can discuss what it feels like to do the work that we all do. And so many of you are leading these really incredible efforts within your institutions, and talk about what that's like. So those of you who are part of Schwartz Center member organizations, we hope you'll join us. Those of you who are not, come join us for our next Compassion Action webinar. The next one on the calendar right now is in June. It's our rescheduled Compassionomics webinar with Dr. Stephen Trzeziak. That should be fantastic. And last but not least, we'll be sending you a very brief survey so we can capture your feedback about today's session. We read every single one of your comments, so please do take a moment to answer that. And that's it, really. Just thank you for joining us. Thank you for your commitment to compassionate healthcare. Take good care of yourselves, and we hope to see you soon. Thanks, everyone.
Thank you to everybody for joining us, and to our wonderful, wonderful panel today. Fabulous discussion. Thank you.